And we're going to start off with a session on medical management. So we're very lucky to have Professor Hart talking to us about acute colitis, and then a session on the investigation of chronic diarrhea. Then we've got an early, we hopefully have a round table discussion after that, which I hope will go as well as it did yesterday. After lunch, we've got a session looking at extended resections in the pelvis and exenterations, and then a video on right hemicolectomy, talk on disaster medicine, and then some management of distant disease with METs, liver METs, and peritoneal disease. So I'm very, very grateful to Professor Ailsa Hart to talk to us today. She's truly a global leader in the management of IBD, sits on committees nationally at the BSG, in Europe with ECHO, and also internationally, really directing the direction of research in IBD across the world. So you can talk to us about something relatively prosaic for her, I should think, but we look forward to hearing about what she thinks about acute severe colitis and its management. Thank you.
Thank you very much indeed for that introduction. Now I'm just struggling to see where the...
Should have done this for you, shouldn't I?
No, I'm sure it's somewhere down here. Ah, there it is. Wonderful. Lovely. So good morning, everyone. Just to find out who's in the room. So is it all surgical trainees? Hands up. Any nurses at all? Specialist nurses? Any one specialist nurse? Wonderful. Great to have you with us. Any gastroenterologists? No. Okay, so I'm feeling quite lonely up here today. So what we're going to do in this talk about acute severe colitis is just reflect on the scale of the problem that we're dealing with here. Think about the medical treatments for this condition, how to optimize these particular options, look at the role of possibly even third-line medical therapy in this scenario, just so that you really understand where this field is going. Really importantly, the role of surgery in these conditions. You're all surgeons in the room, bar maybe one or two people, and really trying to think how the team works together, truly multidisciplinary in this particular scenario. And then just look at what is really going on in the UK and indeed in your own hospital by auditing. So, how do we define acute severe colitis? Well, this is the definition from Truelove and Witts. So it's patients with colitis who are going more than 6 times a day, passing blood in their stools, and then they've got one or more of these systemic features. So they've got a fever, a tachycardia, they've got an anemia, or their inflammatory markers are raised. That's the definition of acute severe colitis. It hasn't really changed since those early criteria were put on the map. What's the scale of the problem? Well, it's common for patients to have this sort of acute severe attack. So 15 to 20% of patients at some point in their disease course will have this sort of scenario where they need to come into hospital. And really importantly, about a fifth of patients, their first attack is acute severe in nature. Now this is a big deal for these patients because they haven't got used to the fact they've got a chronic, long-term relapsing remitting disease. They're just suddenly really unwell. They're stuck in hospital with lots of people trying to do lots of things to them. That's a big psychological burden actually for these young patients. So just remember that about a fifth of these patients, this is their first time at diagnosis. Just a case history, just to again to sort of set the scene really. This is a patient I met a long time ago when I was a very junior doctor actually in this hospital. She's a 20-year-old female, she was a college student at that time, and she came into the hospital with acute severe colitis. She had steroids, didn't really respond, had some rescue therapy with cyclosporin, didn't respond to that, so came to surgery and had a subtotal colectomy done as an inpatient. Now this patient, and I was the SHO at the time, it shows how old I am, was the SHO at the time, and I would go into the room every day, and this girl didn't talk. She didn't talk at all to anyone for weeks and weeks and weeks. She had something called elective or selective mutism, and that was basically that she just wouldn't talk. And I think the trauma of the surgery and the stoma was such a big thing for this poor girl that that was the impact it had on her. So I tell this story just to sort of reflect on the impact this sort of disease can have on young people. She did very well in the long term. She should start speaking again, by the way. What about steroids, the impact of steroids? And again, this slide is just to reflect about how things have changed with time, actually. So way back in the 1930s, the mortality of this condition was really high, 75%. Decreased to about 22% later on in the 50s. But the real change, of course, came when medical therapy like steroids were introduced to treat these conditions. And that's when the mortality really started to drop to more like 7%. Overall now, the mortality in specialist centres is less than 1%. But it is not just steroids. And again, this is probably the most important slide of the entire talk, because it's the attention to detail in managing these patients that I think really impacts on the patient. So make sure they get their intravenous fluids with lots of potassium. These patients are absolutely hosing out potassium, and low potassium can impact on the physiology of the bowel. So make sure the potassium is kept in the range of 4 to 5. Nutritional support. Often these patients have felt really poorly for quite a long time as the sort of the prequel before they get this admission to hospital, and they must be seeing a dietitian who knows about the condition, not parenteral nutrition, but just making sure that they are actually getting some supplemental feed. Subcutaneous prophylactic low molecular weight heparin is absolutely mandatory for these patients. They are highly coagulable. They're likely to get, they've got a high risk of DVTs or even PEs, so making sure they're on the prophylactic heparin is really important. Again, it's mandatory these patients have an unprepared flexi-sig. So you don't need to be giving phosphate enemas or anything like that to these patients. They're going so often, the bowel is pretty clean. And the purpose of that is twofold. One is, how severe does the disease look? Does it look really bad disease? And we'll talk a bit about the endoscopic findings in a moment. And also importantly, to take a biopsy, just a single biopsy to check for CMV. Because if you see virus there, then you need to make sure you're treating the virus separately in these patients. Stool culture is really important. And how often are we all in the scenario where you get patients admitted maybe on a Friday night, you send off the stool cultures, you don't know there's a superimposed infection, you're waiting for the stool culture results to come. If there's any question, you can dual treat these patients with steroids and antibiotics if it's that sort of clinical scenario. Be careful with any of the drugs that might be on these patients' drug charts. So always just make sure you're flicking down these patients' drug charts. Have they got opioids prescribed, or non-steroidals, or anticholinergics? Because again, these are bad news for these patients on the whole. Non-steroidals really contraindicated here. If the patient has got enough pain that they're needing opioid analgesia, they should be seeing probably you as well as us to make sure they're actually being looked after properly. So be careful about that. I've said topical therapy is tolerated because often these patients, when they're inpatients, have real problems actually holding in any enema at all. So it's simply making sure we talk to these patients properly to say, you just need to be a bit of an opportunist here. If there's an evening where you think, let's get some topical therapy in, let's do that, but don't get stressed about it. Any topical therapy in can help, but also just remember it can alter the stool chart that we all look at, which guides our management. Because if they're putting enemas in twice a day, they'll probably go to the loo 3 or 4 times around about the time of the enema. So just make sure you interpret the stool chart in the context of any topical therapy the patients are having. And obviously get the iron levels up, get the blood in as necessary. So steroids work. And the systematic review of all the trials shows that ballpark 2/3 of patients will respond to steroids. That's what we can say to our patients. When you come in, high chance 2/3 of you are going to respond. The flip side of the coin, of course, is that 1/3 won't respond. Now, can we pull these patients out at all? Well, lots of people over time have tried to look at predictors of response or non-response to steroids and indeed rescue therapy. And just to draw attention to some of these, again, in the first 24 hours, the factors of blood in the stool, pulse rate, temperature, hemoglobin, ESR, if they've got 3 or more of those variables, there's a 50% risk of them needing a colectomy during that stay. Probably some of the better known predictors are these ones here, the Ho index. So remember, this is 72 to 96 hours into the admission, and be careful with the timing here to make sure that you are really looking at these early time points. So the Ho index looks at stool frequency, colonic dilatation and low albumin. You can see the scoring system there in the blue box. It's got an 85% sensitivity, 66% will require rescue therapy, about 1/3 colectomy if they've got those sorts of numbers that you can see in the box there. And maybe the best known one is the Oxford score, stool frequency of more than 8 a day or 3 to 8 times a day, the CRP greater than 85, greater than 45. That's got a positive predictive value of 85%. But to be absolutely honest with you, these scoring systems, they are there, they are helpful to guide, but nothing really trumps seeing the patient twice a day, morning and before you go home, and looking at the whole scenario, because sometimes these numbers just cloud that general decline in the patient. So do use these, but I sometimes see the more junior doctors looking very rigorously at these things and saying various things. These are the guide to the outcomes. They help, but I think nothing really trumps the clinical look at the patient at the bedside. What about endoscopy? Well, I'm a big proponent of using endoscopy just to see how we're going with these patients. For all the reasons I've said, look to make sure you've taken a biopsy for CMV and see how severe it is, but also it can help to predict. So this looks a miserable bit of bowel, as you can all see there. The UCEIS score is the score that we should probably all be using in our endoscopy departments now. I think it's better than the Mayo score. And just a hands up, how many people in their endoscopy departments use this score? And I'll be honest, it would be the same number of hands going up for gastroenterologists. What about the Mayo score? Is anyone using the Mayo score? A few hands going up. But it's not enough still. I think we need to be speaking the same language here when we try and actually judge what's going on. The UCIS score is good because it's really simple to use. All you need to look at is the vascular pattern. Is it normal? Is it a bit obliterated? Is it completely obliterated? It's as simple as that. Bleeding. Is the blood in the lumen? Is the blood submucosally? Or is there no blood at all? And erosions and ulcers. And those particular three things have been really good at inter-observer variability, that we can all kind of speak the same language. So just reflect a little bit, take it back to your endoscopy department and say, let's put on the wall the UCIS and try and get used to scoring this sort of system. Again, if you look into the bowel of these patients, if they've got a score greater than or equal to 5, it's bad news, much more likely to be needing rescue therapy than if it's lower. If they've got a score greater than or equal to 7, they really are in trouble. But I think the point I'm trying to make is that with those predictors that I've mentioned, also think about endoscopy, because it can just give that little window in to see, is the mucosa responding at all to the medical therapy? Really helpful if it's not, because it's straight over to you guys at that stage. So 2/3 of patients respond to steroids, 1/3 don't. The other options we've got are, of course, cyclosporin and infliximab. So we've got 2 options now. So what about a question for you? So this, again, is what patients are going to ask at this particular junction in time. They've had the steroids, they're having rescue therapy. What is going to be the likely chance of a colectomy at longish term follow-up, maybe up to about 3 or 5 years? So hands up for 10%. 25%? Okay, quite a few going out there. 50%? 75%? 100%? You're all really quite optimistic. I like it, actually. The answer is 50%. I'll just show you the data for it. So cyclosporin, of course, this was the first rescue therapy that we all used. Randomised trial comparing IV cyclosporin 4 milligrams per kilogram per day. And you can see it's a really small trial. 11 patients in one arm, 9 in the other. Why is it so small? Well, because unequivocally the patients on cyclosporin did really well, so ethically it wasn't okay to continue it. And that was the trial, of course, that put cyclosporin on the map. Then you have the usual raft of, of big data, real life data, but the bottom line and what we tell patients is about 3/4 will respond in the short term. So that's the take-home message for patients with cyclosporin in the short term. Then the question arises, have we got the right dose? Well, no, we didn't get the right dose to start with. So that first New England Journal trial used 4 milligrams per kilogram. 2 milligrams per kilogram is perfectly fine without some of the toxicity. So the right dose is 2 milligrams per kilogram of cyclosporin IV. So I've said the rules of engagement here. This isn't sort of to be undertaken lightly in a way, because if your hospital isn't used to using cyclosporin, indeed the nurses on the ward and so on, it's a slightly difficult drug to use. So it is really important that there are clear algorithms and the nursing team know exactly what to do. So the homework tests for any of these patients are, you check the magnesium, you check the cholesterol. If those 2 things are a bit low, this drug is more likely to go across the blood-brain barrier and the risk of seizures is a bit higher. If they've got low cholesterol or low magnesium, you need to know about it. If the magnesium is low, it's easy. You can just top them up. The cholesterol is a bit more difficult. Use the 2 milligram per kilogram dose and wean the steroids. By definition, these patients probably aren't responding to steroids at this point. You don't want them on too many immunosuppressing drugs. Be a bit careful with patients who are older, and I think we're all going to be facing older patients with these diseases, and all the risks go up medically and surgically. And patients with hypertension, and indeed consent patients to the risks of neurotoxicity, that's the chance of having a fit, or indeed kidney toxicity, nephrotoxicity. Can't use if you don't have the right help, so get the nurses, get the pharmacists on board. And make sure you can get drug levels. And it is really hard in some hospitals to get drug levels because you need to get these patients within a certain range. Too high and the toxicity is there, too low and they're not going to get the therapeutic benefit. And can't use if there's no way out. So cyclosporine isn't a long-term drug for these patients. It's a bridge to a different drug. So if patients are naive to azathioprine, make sure you're again doing all the homework tests, this enzyme TPMT, so that should be in the pipeline for that, so you know what you're going to bridge these patients to and plan that exit strategy. Normally it's 3 months of cyclosporine, that's the bridge, and then these patients run along with azathioprine after that. And this slide just demonstrates that. So you can see in the fourth column along there, colectomy avoidance if they're on azathioprine is much higher than if they're not on azathioprine. So if patients haven't been on azathioprine when they come into hospitals, they're naive to that, starting a thiopurine after rescue therapy, that reduces the long-term risk of colectomy. Compared with patients who are on azathioprine, then they have their flare, then you haven't got anywhere to bridge them to. So again, that's a different scenario and you might choose a different drug in that scenario. So here's the long-term benefit of cyclosporine. It comes down to that multiple choice question I asked you a few slides ago. So what's the long-term outcome? Well, about 50 to 65% of patients will avoid colectomy at that longish term follow-up out to 3 years. That's the sort of number we can be telling patients. So that's cyclosporine. Remember, we've got the other drug as well, infliximab. Small trial again, initially put this drug on the map, 45 patients with severe colitis, randomized to infliximab or placebo. And the primary endpoint was colectomy or death at 90 days. Infliximab 1, this was the intention to treat cohort there. So you can see that the infliximab in the blue, the percentage of patients operated on at 3 months was significantly lower. So that was the first trial, the Yannerot trial, and indeed when they've grouped all of the trials together now in a systematic review and meta-analysis, 34 studies looking at infliximab. The short-term response is about 2/3 of patients. So again, that's what we can tell these patients in the short term. The longer-term response is pretty much the same as cyclosporine, so 50 to 65% of patients. So it's easy. It's a really easy sort of discussion with patients. You've got these two drugs and your chance of not having a colectomy in the long term is of the order of about 50%. So decision time, when to avoid cyclosporine, when to avoid infliximab. Well, there are clear reasons to sort of avoid one or the other. You know, elderly, we've talked about, this is the most difficult group to treat for all the reasons I've said. Be careful with cyclosporine if the patient's hypertensive, got renal problems, low magnesium, low cholesterol, or indeed if they're already on azathioprine. For infliximab, you've got to be careful with risk of TB. It's a particular problem in hospitals like this. There's quite a high risk of TB in this particular area, demyelination or severe heart failure. So any head-to-head trials? The answer is yes. There are 2 head-to-head trials, one from France, the CSIF trial, and one from the UK. This is the CSIF trial here. So it's a randomized, open-label 3-month study, over 100 patients put on either infliximab or cyclosporine, and you can see the endpoints there. There is no difference in this head-to-head study of cyclosporine versus infliximab, so no significant difference in how effective the drugs were, in colectomy rates or adverse events. That's the French study. What about the British study? Well, this was a really neat study actually that John Williams did from Swansea. Why? Because it was a pragmatic study, pragmatic randomized trial. Again, head-to-head, cyclosporine to infliximab. What they looked at was cost effectiveness, what we think of the drug, what the patient thinks of the drug, as well as all of the normal sort of endpoints that were looked at. This was their primary outcome, so very rarely do you see this sort of outcome as a primary endpoint in a trial, but this is what this trial did, and it really put these sort of pragmatic trials on the map. No difference between the 2 drugs regarding quality adjusted survival. But then if we look at the things maybe we're more familiar with looking at, colectomy, either in hospital, short term or long term, there is no significant difference between the 2 drugs. So 2 randomized trials, one French, one British, there was no difference between these 2 drugs. And then if you come to, again, group all the studies in a meta-analysis, that it completely sort of reinforces the point I've made. There is no difference between cyclosporine and infliximab. If you look at the non-randomized studies, there does seem to be a high response rate for infliximab and a lower 12-month colectomy rate. So it's just an interesting point to note, but that's from the non-randomized data that was pulled from. So now just imagine this scenario. The question, just to make sure everyone's awake, you've got a patient with acute severe colitis. they've had IV steroids, and 3 days after you've given them infliximab, 5 milligrams per kilogram, they're still in trouble. They're still going about 5 times a day, the CRP is up. What are we going to do? We're going to give another dose, 5 milligrams per kilogram? Are we going to rank it up to a double dose? Are we going to go from infliximab to cyclosporin? Then the patient's on steroids, got infliximab in them and another drug. Is it time for surgery? Or are we going to watch and wait? Who thinks more infliximab? This is a silly question really to be asking all of you. So we've got 1 for infliximab there. What about 10 milligram dose? Yes, good, Chris. Well done. Anna, what are you thinking? Surgery, probably.
Yeah, I am actually.
Cyclosporin, any takers? That's probably the least beneficial one there. Surgery. It is a room of surgeons. So we have one sort of slightly more conservative surgeon here, or watch and wait. Okay. So just to think a little bit about infliximab, because I think it just makes the point, there's so much we do not understand about these monoclonal antibodies in this particular scenario. So patients who don't respond early on, these really hot colons when they're so inflamed, these patients are just leaching the drug out into the lumen, and we can measure infliximab in the stool. So patients who've got low albumins, who are clearing the drug, who are pooing it out, they just have really low levels. Their levels go up and they go down. Unlike the patients who are quite well in the outpatient, where you can keep the levels a lot more sort of level. So these patients are quite different. They behave quite differently with infliximab. There is no randomized data here for giving bigger doses of infliximab, and that's a really important point to note. But this just small study did suggest that accelerated infliximab might be helpful. So like that scenario I've discussed, where they've had steroids, they've had 1 dose of infliximab, giving another dose fairly soon after, particularly in patients who've got low albumins, they could be the patients who do reasonably well with it. So the accelerated strategy here had a decreased need for colectomy. So this sort of strategy is beneficial maybe in 50 to 80% of these patients, no randomized data, and a little practical tip. If the CRP fails to fall below 50 after 3 days, that could be your nudge to give more infliximab. But I am actually on the side of most of the hands that went up, that this is the moment to be thinking very carefully about surgery. Again, just that you can see the conglomerate of data here. So this is putting together all the systematic reviews of using sort of third-line therapy. So that's now they've had steroids, they've had either infliximab or cyclosporin, whichever order, and you're going to give a third-line drug. This, I have to say, I think is getting into quite dangerous territory. I think medically, I have anxieties here about using this, but this is the data from the systematic reviews, and it looks reasonably okay. Short-term response of 62%, colectomy rate at 12 months of 42%, but you can see you start to get some trouble with regards to infections, and indeed there's a mortality. The ECHO guidelines state, and this is new from previous ECHO guidelines, that sequential or third-line therapy can be considered in selected cases in referral centres. Previously, I would have said, caution, don't do it. But I think maybe in the right patient, for example, if there's an elderly patient with maybe major surgical comorbidities or reasons not to, this is a reasonable strategy to do it. But it comes down to, and I think this is again maybe the second most important slide of the talk, and this is communication. And this is communication actually between us, between me and you. And this is where patients can get very inconsistent messages sometimes. And I've even had phone calls from a patient in another hospital with acute severe colitis in their bed saying, well, the surgeon said I should have the medical therapy and the medical doctor say I should have the surgical therapy. What should I do? And what's gone wrong there is that the people haven't got round the bed and discussed the pros and the cons of everything going on here. So it's simple communication, like so much of decision making is in IBD. So it's getting the surgeons and the physicians round the bed with the patient and any family members, because it's tough for these patients. They're sick patients and decision making is particularly hard. So for patients who are just thinking, I don't quite know what to do, get the right people round the bed to help make the decision. Those are the predictors of trouble with surgery. You're very familiar with all of those. And of course, steroids, that's the major drug, which is the impact on poor outcome. But often these patients are just on steroids. That's why they're in hospital. No evidence that cyclosporin acts poor outcome. Infliximab, it's still a bit debatable. Just a bit of data from the IBD audit. Again, the UK's done a phenomenal job at trying to collect data and audit what's going on. So you can see very neatly, this data just goes up to 2014, so I'm sure it will be changing more and more. Cyclosporin was sort of quite a few people were sort of just evening out, infliximab was going up. And I think if we redid this audit now, infliximab will be going way up and cyclosporin would probably be going down, despite those two randomized studies saying they're both the same. Again, just a key point to make this practical, the proportion of hospitals which had guidelines to try and help manage these patients has gone up happily over this time frame. So if you don't have this sort of guideline in your own hospital, make sure you have something, a single bit of paper where the junior doctors can be ticking off, have I checked the magnesium, the cholesterol, the quantiferin, all of the homework tests. Look at day 3, look carefully to make sure surgeons are involved from really early on to help the decision making. And if there's a tick box, it'll try and just streamline the management of these patients. So just to draw that together, these patients are sick patients. Remember that 20% of these patients, this is their first moment of diagnosis of IBD. So it's a very confusing time for these patients. So education, I think primary care and indeed patients to ensure tight monitoring, trying to limit these patients even getting to the stage where they become acute severe. Sometimes it's how the disease goes, but even trying to manage these patients as optimally as possible as outpatients can obviate some of that. It is a severe disease, it's got a mortality, and that slide on attention to detail, all of those things to make sure you're really tightening up on that management is important. Steroids are first line. You've got the pick of either cyclosporin and infliximab second line. Be judicious and careful with third line, but it's got its role, I think, in very selected patients. Surgery is key in these patients. Getting the right people around the bed to help the decision making is very important. And make sure you've got a checklist and a pathway in your hospital so you can audit what's going on. Thanks very much indeed.
Brilliant talk, as predicted. So there must be some questions from the floor, I should think. Yeah, plenty of them.
Do we know if the same patients respond to cyclosporin as infliximab? Is it the same 2/3 of patients? Are they just people who are going to respond and people who are not going to respond?
No, it's
or do some respond
question.
better to one or the other?
It's a brilliant question, and the answer is we don't know if it's the same group of patients. There's so much work going on globally at the moment to try and work out biomarkers of response to a particular drug. You know, can you look into a crystal ball at baseline when you get your diagnosis? Are you going to be an anti-TNF responder or a drug B, C or D? We don't know. You know, I think probably there is quite an overlap though. Some of these patients are just going to be refractory patients and they've just lost too much ground that so it's the point, almost the disease has just got a grip somehow. But we don't know the answer. It's a very good question.
I was wondering about that. So when you talk about third-line therapy, are you talking about a switch from infliximab to cyclosporin or vice versa, or are you talking about methotrexate or something?
No, correct. No. So it's patients who've had steroids, then they've had cyclosporin, then they have infliximab, or steroids, then infliximab, then cyclosporin. Yeah. And a few years ago, I would honestly have said, no way. Yeah. There's just a sense now that it depends on the scenario. If you've got a patient where you guys are saying, you know, this operation is going to kill the patient, then I think maybe the infective risk, and infection is the big thing. Then maybe there's a role for third line.
What day do you, I mean, obviously it depends, but we're thinking about day 5 to 7?
For the third line switch?
Yeah.
No, so I think, you know, I think if they're on infliximab, what we are now understanding is that you just push infliximab a little bit more rather than moving to a different drug. Yeah. If they're on cyclosporin, make sure they're in range with the cyclosporin. Cyclosporin washes out quicker. That's the good thing about cyclosporin, is that then there is possibly a chance of going to infliximab, but you know, if you're looking at the end of the bed, and if this is going only one way, they're declaring themselves.
Make the decision.
And it's just, you know, what's the role of surgery here, or what's the role of medical therapy here? It's trying to get a lot of these patients into calmer waters, to my mind, when they can make their decision in outpatients, and they, you know, a lot of these patients are coming to surgery, but they sometimes need just a little bit more to sort of getting there to psychologically deal with the chronic disease as much as anything.
Thank you. Right, we have a question over here.
Thanks for this brilliant talk. Just got a question about when do you recommend the first contact between the gastroenterologist and the surgeon? Because quite often we see the surgeon says IBD is a medical problem. They need to exhaust all the resources first before they contact us. And then we see the gastroenterologist say we need to get the surgeon on board.
So what do you think?
My own view is as early as possible we need to be on the scene just to be prepared for what's coming
I
next?
think it's belt and braces. It's exactly as you say. What's the harm in that? You know, sort of every week in our MDT, any patient who's an inpatient, they'll be tagged as that. They will know. The surgical team will know. Now, if it's all going the right direction, you know, it can be very light touch, but it's knowing. So the patient isn't suddenly, these are sick patients, suddenly, you know, having an army of people all around them, all saying different things. That it's very hard to process if they know the face. If they know, hopefully they're not going to need to see you again, but it's just that's a relationship forming part of it, I think.
Right, thank you. Just second question, sorry. Would it be different if the flexi-sig came and say probably Crohn's colitis, severe Crohn's? Will the management will be the same or will be different?
Yeah, no, I mean, that's another very good point. So I think that would be a reason to go to infliximab, not cyclosporin. There's less data that cyclosporin is good for Crohn's disease. So that would definitely tilt towards using infliximab as the rescue therapy if needed. And then, you know, you just see how things go. You see the response to therapy, and then obviously it has implications on surgery down the line. But the initial surgery, if it's needed, it's going to be done, and the same operation probably will be done as well initially.
Thank you for the talk. Again, bringing back to the surgical ward, how do we manage those patients post-operatively? So this patient who was on rescue therapy, perhaps even a third-line therapy, they had the subtotal colectomy, but they presumably still got an inflamed rectum. So do we taper them down? Can we sort of stop them because the rectum's now defunctioned, or what would be your policy?
Yeah, so I think easing off, backing off, getting them off steroids is obviously really helpful. If they've been on infliximab and the rectum is still relatively inflamed, it depends where the whole thing is going really in the longer term. Some topical therapies can just be the sort of thing to get into the rectum to soothe it. If, you know, these patients are either going to have their rectum out in an endostome or they're going to have a pouch. These are not going to be IRA patients if the rectum's really sore. If you ever do want to salvage the rectum properly, then you might need to continue the more biologic therapies. But generally speaking, we get them off steroids, get some topical therapies in, and get them off the drugs. Get them off the steroids. You guys then have got the time for the patient to get used to their stoma, and then off they go with the more reparative surgery down the line.
But you would continue the infliximab or cyclosporin if they were on it before?
Continue the infliximab or cyclosporin if...
So day one post-operatively, or the first week post-operatively, we taper down the steroids.
And stop the drugs. Stop the drugs, yeah.
Are there any predictors for where you might be able to salvage the rectum and where you might not, in terms of thinking about IRAs for treatment?
I mean, we haven't done many IRAs here, and it would normally be a rectum which is looking like an okay rectum to start with. Yeah. So, you know, you will know more than I do about, you know, these sorts of groups and when to sort of really discuss that with patients. It's almost, again, a stepping stone often for patients who don't want to go the whole hog. You know, I think actually the surgical options for these patients is a big discussion with patients.
I think
still.
IRAs are getting a little bit more traction in recent times.
Yes,
yeah,
yes.
As an option,
I think the Swedish have maybe slightly influenced thinking a little bit there. I think it's maybe a slightly different cohort of patients they're doing it on. But generally speaking, you know, this is complete rectum out, endostome or pouch will be the general thing, just to make sure that's clear.
Any other questions?
So a quick question about doing a flexi-sig on these patients. When do you wait for them to respond and then examine the bowel? And also, how does delineating the extent of disease guide your management? Does it just give you a picture of how severe things are and how likely they are to respond or maybe not respond?
No, you know, excellent question. So initially, when they come in, they need their flexi-sig just to get a gauge of how severe. And don't worry if you don't get above the limit of it. It's more just how severe it is. The limit of it is quite irrelevant, really, for the management at this stage. And to take your biopsies for CMV and that sort of thing. Then using it more as a predictor of how the disease is responding or not to therapy, you can do that when you're sort of thinking, right, do I move to rescue therapy, blah, or do I even move to third-line therapy? Because if you begin to see the mucosa responding, and some of these patients do, if you look into the bowels at about 3 to 5 days and think, okay, yes, we're beginning to see a bit of regenerative mucosa there, you know, it's maybe pushing, let's carry on. If it's doing absolutely nothing and really all the numbers are adding up and we're just looking at the patient thinking, no, then you know it's a clear decision. So it's helpful to push it in either way. Of course, there are lots of patients when it's sort of sit in the middle And then it is tough decision making. I think it's the hardest decision in the IBD book, this call of when to do a colectomy in these patients often. And normally I'm a big proponent of the patient helping to make the decision. Often these patients are too sick to be really clearly thinking about some of this decision making, so it is us to guide them a lot.
I do have a question actually. Do you ever send people home with extended prophylaxis for heparin, low molecular weight heparin?
Yes, I mean that's a good question. So there's the paper in the Lancet a while ago, showing that outpatients with IBD have still got quite a high risk of thrombotic problems. So no is the practical reality.
Last Christmas, who came in at the age of about 75, first presentation of UC.
Yeah.
And it's sort of settled, and he went home, and he came back, and it settled again. He went home, and then on Christmas Day, he dropped dead with a PE.
Right.
So that's very much in my mind whether that's something I should have done. It's certainly something his wife is asking whether we should have done.
Yes.
Yeah.
Yes.
The other thing was, what antibiotics do you recommend if you're unclear about whether this is an acute ulcerative or infective colitis at the outset? What antibiotics do you choose to treat the patient with?
So come with a bit of metronidazole. C. diff is probably the major thing you need to be thinking of. So if there's any sort of worry, I think don't. If you're thinking, is this infective, is it IBD? If it's literally that junction diagnostically, metronidazole plus steroids. But if it's Friday night, don't not give steroids.
Yeah.
I think that's probably more detrimental than co-treating, and there's certainly data to support that.
Great. Any other questions? Well, thank you very much. That was, it was a huge literature. Summarised beautifully and very clearly. Thank you very much. Right, Anna Wilson is going to now talk to us. She's been here for about 6 years now. Are you loading up with a stick? Yeah. So we're now going to talk about chronic diarrhea and its investigation. We see quite a lot of patients come in with change in bowel habit, and often it's to a looser stool. I see patients come back to clinic and they've still got ongoing diarrhea. So for me, rather than passing it off straight to the gastroenterologist, I'd quite like to know how you go and investigate these patients. So I'm hoping that Anna will give us some markers and some guidelines as to what to do.
Wonderful topic, which made me feel as depressed as it does when I have these patients in clinic. And roughly about 50% of patients I see in clinic have this. And it's very kind of you to think from a surgical point of view. In fact, actually, I had one of my new consultants from Leeds, Daniel Omiskowicz, referred me a patient the other day and said, I've already organised the CCAT scan, so it's all sorted. I nearly fell off my chair. I was like, oh my God, what am I going to do now? Chronic diarrhea is not sexy, it's not changed, there is no new data, and it was actually quite difficult approaching it because short of rehashing a textbook for you, it was quite difficult to see how we were going to talk about this. But what I thought I'd do is have a bit of a practical management in terms of what I do with these patients, and then we can have a debate who you think should manage them. And some of these decisions are really made locally. They're made in your department together with your surgeons, who has the best skill set, but also who has the most interest, because lots of these patients, particularly when we start talking about the functional ones, just need someone to take a bit of interest, and they're slightly different than your routine surgical 10-minute appointments. So this is my real bugbear. When patients come in and say, I've got a diarrhea, what do they actually mean by that? And they come in saying all sorts of things. They mean all sorts of things. They mean just a bit of change in bowel habit. They mean that they've got watery stool, they mean that they've got loose or semi-formed stool, they've got fecal incontinence, flatulence or steatorrhea. So these are all things that patients have when they come to you to clinic to say they've got diarrhea. So one of the most important things before you come to any investigations is trying to elucidate what actually patients have. And And so this is a definition of chronic diarrhea. It's relatively arbitrary, but the one that seems to work and the one that we seem to use for categorizing these patients. So they have to have loose stools, and that's Bristol stool chart, and that's quite easy for patients to see, somewhere between 5 and 7. They have to have an increased frequency as well as altered consistency, and we usually talk about more than 2 or 3 times a day, depending on which paper you read. And again, arbitrary definition, but what we define as chronic diarrhea is anything lasting more than 4 weeks, because we think that any acute infective cause would be resolved by then. In the old days, we used to talk about stool weight. No one has done stool weight for about 20 years in the UK. And we also know that stool weight really varies, and it varies what type of diet you have. So the definition of stool weight of that you have to have more than 200 grams a day is based purely on Western style diet, and we know that's not the same worldwide, so we don't do that anymore. Again, I'm sorry, going back to basics, bit of a textbook thing, but I sort of think it's always really quite important to consider is what is actually diarrhea. Diarrhea is simply incomplete absorption of water from the intestine, and that is either because there's decrease in absorption or increased secretion. And think about it in this sort of way, just helps you stratify how you're going to investigate the patients and which route you send them down. We can divide diarrhea into osmotic, secretory, inflammatory, and with altered motility, and I'll talk about this a bit later on. And again, the only point of dividing them into different subgroups is to try and think about etiology and try and think what investigations we do and in what order. So I suppose when you're confronted with someone in clinic and you think, in the surgical clinic particularly, the first thing you want to exclude is colonic neoplasia. So this is the list order of sort of organic pathology. So you want to exclude colonic neoplasia, you want to exclude colonic inflammation, small bowel inflammation, small bowel malabsorption, maldigestion, which here the common one is, the most common one is pancreatic insufficiency, and then motility disorders. I suppose from a clinical point of view, it helps to characterize diarrhea into these different types because you are just going to investigate them slightly differently. So inflammatory diarrhea tends to be frequent, watery stools, lots of tenesmus, and then lots of those markers of generally feeling unwell, plus or minus fever, raised inflammatory markers, raised fecal calprotectin. Fatty stools, obviously steatorrhea. And interestingly, although people often talk about floating stools in the toilet, that's not a mark of steatorrhea. The stools float because of gas produced by colonic bacteria in a stool. It's a liquid film or stool that are very difficult to flush away, or oily film on the toilet that's very characteristic. And then we have watery diarrhea, and it is quite important to try and work out whether it's osmotic or secretory because of very different etiologies. So, watery diarrhea. So, osmotic diarrhea is by far the commonest cause of diarrhea that we're going to see in clinics, so having excluded anything else. And that is a result of poorly absorbed ions and anions. So people taking magnesium supplements, taking laxatives, antacids over the counters. Carbohydrate malabsorption is one of the biggest factors and commonest that presents in gastroenterological clinics, with lactose malabsorption being the commonest one. But we'll talk about these lovely foods called FODMAPs, which are actually increasing probably in symptomatology and prevalence. And then the secretory diarrhea tends to be typically organic causes. They tend to be very much related to food and often will stop when patients are not eating. So these are the patients who often come and see in clinic and say, I haven't eaten, so I can come and see you in outpatients. It's not always the case, and certainly not when you start talking about functional aspects such as irritable bowel syndrome. So I thought I'd put this up, not because you'll be able to read it, but to direct you to this fantastic guidance, which I sort of thought I would just put up one slide and say these are the guidelines for management of chronic diarrhea. So BHG have done a really grand job of producing extensive guidelines for how to manage chronic diarrhea. It's an update to previous guidelines, which I think 2002 or 2003, and they're all encompassing, but they're incredibly complicated in how to use them. This is what Mayo Clinic uses, and I quite like this because it's much easier. But of course, it does rely on you trying to describe whether the stool is, whether you think diarrhea is inflammatory, fatty, or watery. And then it simply takes you through the various algorithms depending on what the diarrhea is like. So for inflammatory causes, colonic evaluation comes very high up. For fatty diarrhea, you're either thinking pancreas, small intestinal bacterial overgrowth, which is what SIBO stands for, or mucosal causes. And then for watery diarrhea, you have the secretory osmotic types, which we will discuss in a bit more detail. I guess a simplified approach, and the one that I would recommend using in clinical practice, is establishing if the patient really has diarrhea in the first instance. Have they just got fecal impaction? Are they just incontinent and they're calling it diarrhea? Because that doesn't need all investigations that we're going to go through. Medications are a big hit on the causes of diarrhea, and they tend to be obvious things, which we'll go in some detail later. And how they cause diarrhea really varies, from protein pump inhibitors causing microscopic colitis to metformin. The etiology of the diarrhea is still not clear, but it's probably to do with altering the secretion of sodium and chloride and therefore absorption. We need to establish whether it's acute or chronic. And then again, as I showed you previously, I think establishing whether it's inflammatory, fatty, or watery does help guide further investigations. And one thing always to consider, and this is really after you've exhausted all the investigations, is this diarrhea factitious. And for some of these patients, we do end up admitting them to really try and work out have they got diarrhea or not. And that's after you've exhausted every single possibility. I put this up, and these are the textbook things, but I thought it's quite important just to review what are the common things. Common things being common need a sooner investigation. They're going to come up high in your algorithm of excluding rather things that are rarer. So I suppose by far the commonest thing that I would see in my clinic is diarrhea predominant irritable bowel syndrome. Bile acid diarrhea is something that often gets forgotten about. Diet, we'll talk about in a bit more details. And as you see, the organic pathology, colonic neoplasia, IBD, celiac disease are significantly less common, and then overflow diarrhea sort of creeps in there, although hopefully we would have excluded that at a first port of call. The very infrequent causes, I'm not going to read them all for you, but important to know them. And I think it's just important to keep things in your head just for managing your own algorithm. And things that are really rare that I have sent off maybe twice during my career as a consultant are things like vipomas, gastronomas, and carcinoids, so fasting gut hormones, etc. I mean, that's really rare, and that's not what I think you should be doing in surgical clinics. But of course, important just to be aware of things if we're not coming up with a positive diagnosis beforehand. So these are the guidelines, and it's sort of, as we said, I think it's important to make a decision at your local level how much you investigate and how much you send on to your gastroenterology colleagues, because bear in mind, a lot of stuff that we see are already some of these patients. I guess assessing the patients in clinic, or what I do when I assess them, some of the risk factors are really important to identify early on to give you etiology of what it's likely to be. And the things that we always look for is family history of celiac disease, inflammatory bowel disease, colorectal cancer, previous surgery, resections, cholecystectomy. We know that about 10% of patients after cholecystectomy will develop chronic diarrhea because of the enterohepatic abnormal circulation of bile. Previous pancreatic disease, and patients with chronic pancreatitis can have a lag up to about 10 years from developing first symptoms of pancreatitis to developing severe profound steatorrhea. Systemic disease, thyroid, diabetes. I was very excited when I started clinic here for managing patients of consequence of cancer treatment. My very first low anterior resection syndrome patient that was referred, my very first tertiary patient, I was so excited, had thyrotoxicosis. And it's the first ever time I've ever picked up thyrotoxicosis. But it's just important to think about systemic disease and the effect on the gut. Alcohol is a really big one as a diet. We'll talk about diet in a moment. Drugs, and then obviously it's travel and recent antibiotics are usually often picked up in history. So I think that this gives you sort of some pointers about where you go in terms of your initial investigations. And what do we do in clinic? I mean, I'm sorry, this is very medical. It's really not exciting, and it's really not been any different for as many years as since you've been in medical school. But it's looking to try and exclude organic cause of disease. I suppose the importance of this is that knowing that your diarrhea predominant IBS is one of the biggest single prevalent things that you're going to see in your clinic is trying to encourage us to try and see whether we can make a positive diagnosis of IBS without resorting to too many expensive tests. How many tests can you do before you make a positive diagnosis of diarrhea predominant IBS? What else do you need to do? And you know, we've all chosen to work with a very primitive organ. I mean, gut is an incredibly primitive organ. Whether you've got cancer, whether you've got irritable bowel syndrome, whether you've got lactase malabsorption, you have the same symptoms, and symptomatology doesn't really help you distinguish. So we have all these invasive tests that we do, and it's really important to use them in the right people. So what you're looking with your blood test is really trying to exclude organic pathology. TTG, less familiar, everyone gets a celiac test, everyone gets thyroid function test, liver function test for looking for low albumin, B12, folate and calcium are there to look for signs of malabsorption that help you with your small bowel malabsorption. Early presentation of HIV is often with looser stools. Always have that in the back of your mind if there's any suggestion in the history. And if someone's had recent antibiotics, C. diff has always got to be at the front. Not only because there is a really well-recognized phenomenon of post-infectious IBS, and we see that a lot in C. diff, so you've cleared C. diff, but they've got the same symptoms, but also because you get really early reinfection. So C. diff is actually quite tricky. So you always now do PCR and toxin. So if it's only PCR positive and toxin negative, don't treat as a repeated C. diff infection. That is likely just gut not functioning quite right and getting to this post-infectious IBS territory. We use quite a lot of fecal calprotectin, and it's only really helpful when it's negative, so when it's less than 50, because then you can say the risk of there being an inflammatory disorder is minimal. It's not terribly helpful if it's positive. I've had patients who had fecal calprotectin in their thousands. We did an endoscopy and colonoscopy and MRI small bowel and a capsule, and it's all been normal, and they've eventually drifted down. So, you know, positive calprotectin is not terribly helpful as a one-off. It's incredibly helpful in monitoring patients with inflammatory bowel disease, response to therapy, and predicting who's going to relapse early. But as a diagnostic test, it's not really helpful. FIT is about to come in. Lots of European countries obviously already do it, and looking for fecal occult blood test using immunological testing. As a really important thing to say is that we need to try and consider positive diagnosis of IBS in anyone who's less than 40 and has got no red flag symptoms. And the Rome 4 criteria for IBS is actually superseded significantly Rome 3 criteria, partly because they've also excluded lots of other things that we see in clinical practice. But this is what I now call IBS. And the way I phrase it to my patients is your gut is not working properly due to some of these things, which include motility disturbance, i.e. how quickly the contents and the stool move through your small and a large bowel, excessive visceral hypersensitivity, altered mucosal immune function, which we know both at the gut level and systemic level, and altered gut microbiota. And we know there's quite a lot of research showing about gut microbiome actually mediating the visceral pain responses. And, you know, don't forget, enteric nervous system is a huge automated system that works largely on its own, that can be influenced by the central nervous system, but actually can function without any central nervous system or peripheral nervous system. And we know that some of these patients have altered central nervous system processing. And this is a real advantage of Rome 5 criteria. So just to remind you, these patients have to have recurrent abdominal pain, on average at least 1 day a week in the last 3 months. And it has to be associated with 2 of the 3 criteria. Either it has to be related to defecation. We used to previously say that it's relieved with defecation. We know that some of these patients actually have worse abdominal pain after defecation. And you might have had those patients in clinic who say that when they're on the toilet, they sort of nearly faint afterwards. They've got terrible pain, really terrible vagal symptoms. Associated with change in frequency stool and a change in form or appearance of the stool. And the criteria fulfilled for the last 3 months with symptom onset at least 6 months before diagnosis. And important thing is that there are different types. So there is a constipation predominant type, diarrhea predominant type, and then to make it all really nice and complicated, there is a mixed bowel habit type. So your patients are going to fit in one of them likely. What worries us about this, about positive diagnosis? Well, it is the fact that we know that colorectal cancer is on increase. We know there's an increase in younger people. We know that epidemiological data from STAGE shows that a risk factor in patients aged 40 is now probably higher than those in our screening range for various factors. So 40 might not be a good cutoff. You know, I'd probably go in my clinical practice less than 25, and actually everyone more than 25 who comes to secondary care for investigations of chronic diarrhea probably ought to have some colonic endoscopic investigation. So what do we normally do? Well, we would only do OGD and duodenal biopsies if you really have strong suspicion that there is a small bowel malabsorption. So celiac disease, which is often picked up just on TTGs, and you still need duodenal biopsies for confirmation. And bear in mind that if someone's got really strong family history and really strong symptoms of celiac disease, it is worthwhile doing duodenal biopsies because 10% of the patients will have negative antibodies. Colonoscopy is what most of these patients get, don't they? And I mean, I think that's right. They have come through primary care. And bear in mind, the GPs refer probably less than 10% of their IBS-C type patients, less than 10% of patients with diarrhea. So I think once they come through secondary care, The patients want reassurance to a degree. They want a bit more investigations. And by definition, they're trickier patients to settle just with conservative management. We want to exclude that they have cancer. That's why they come on a 2-week wait, and inflammation. And then once you've excluded that, and we'll talk about macroscopic inflammation, so Crohn's and ulcerative colitis, as well as microscopic colitis, which is when colon looks normal. Once you excluded that, then you can consider positive diagnosis of diarrhea predominant irritable bowel syndrome. And we sometimes use capsule. We only use capsule endoscopy if we really have strong suspicion of small bowel pathology. And I always put this slide up. This is a slide that was lent to me by Ralph Bishops, who, the interesting thing that this patient, all of these patients, they're all different patients, all these patients present with diarrhea, and all the pathologies on slides are entirely different. But you can see, I mean, this is my just reiteration of gut is very primitive. The only thing responds is a bit of redness, bit of inflammation, and you get diarrhea. So you've got to sometimes look really quite hard to find out what the etiology is. What about fat malabsorption? Well, I can see quite a lot of these patients actually, because lots of patients who've had chemotherapy or radiotherapy end up getting fat malabsorption to a certain degree. So these are patients who come in with fatty stool, and it tends to be either due to mucosal disease, so celiac disease, Whipple's topical sprue, or inadequate bile acid function, and I'll talk about that in a moment, or of course structural abnormalities. But by far the commonest and the one to give you the greatest amount of fat malabsorption is pancreatic exocrine insufficiency, a result of chronic pancreatitis usually. The thing to bear in mind is that it's not just fat that's malabsorbed, it's fat-soluble vitamins as well, and these patients always need those checking. Fecal elastase is the test of choice. We don't do the collection of stool for 24 or 48 hours fecal fat measurement, which is incredibly cumbersome. Fecal elastase is a very good, easy test to do. Normal level should be between 2 and 500. If it's less than 100, a patient's got pancreatic insufficiency. The thing with fecal elastase that's really quite helpful is that it's not affected by either supplements or the diet. So it doesn't matter if they're already on creon, it doesn't matter what diet they're having, fecal elastase is still going to be the same. But do bear in mind fecal elastase in very watery diarrhea, because of course it gets diluted, so it might be falsely positive because it's just less of it because it's diluted in a large volume of stool. Pancreatic imaging, that's not changed much. We still use CT, but the CT is actually very good only for the advanced disease. If you're looking for very early duct change, very early pancreatic disease, we know that MRCP and US are significantly superior. But for sort of gross disease, long-standing chronic pancreatitis, CT is still the thing to go to. So I'm just going to talk about a few specific conditions that we see a lot of. I see a lot of in gastroenterology clinic. I see an awful lot of these in patients who've had pelvic radiotherapy, particularly women, gynecological women who've had both external radiotherapy and brachytherapy, because their terminal ileum gets hit in the process of radiotherapy and they stop being able to reabsorb bile salts. Just a little reminder about bile salt malabsorption. Bile salts produced in the liver, stored in the gallbladder, CCK after you eat some fat, released into your duodenum, reabsorbed in the terminal ileum via enterohepatic circulation. If they go into the colon doesn't like it, as I say to my patients. In fact, what it does actually is stops sodium and chloride reabsorption, and you end up getting watery diarrhea. Incredibly satisfying condition to treat, because once you give them treatment, they get better if you have it in the right group. The problem with bile acid diarrhea, the same as irritable bowel syndrome, diarrhea predominant irritable bowel syndrome, the symptoms are the same. But actually now, looking back at some of the patients with diarrhea predominant IBS, we know that up to a third of them will have bile acid malabsorption. Now, whether that's a feature of diarrhea predominant IBS or whether that is patients who we mislabeled, it's not quite clear because lots of these things are multifactorial. So the way we tend to divide them into different types depending what the etiology is. So your type A bile salt malabsorption is the things that we would often see in surgical clinics. If you had ileal resection, if you've got ileal inflammation, so Crohn's disease, you're going to get bile salt malabsorption. Type 2 happens in population, 10–15% of the population will get idiopathic bile salt malabsorption at some stage in their lives. Now, interestingly, that only matters depending on how fatty food you eat. So you might have lots of people who, on paper, will have bile salt malabsorption, but because they naturally will be eating very low-fat food, they don't have any symptoms. So bile is not. You only develop symptoms if a bile exceeds a certain concentration in the colon. And then type 3 is what we label to various other gastrointestinal diseases, such as small intestinal bacterial overgrowth, celiac disease, chronic pancreatitis. CCAT scan is the scan of choice in UK and Europe. It's not available in USA, where they use a blood test. It's been really used since about 1980s. It's radioactive labeled taurocellic acid. And then that on the right is a gamma camera. Patients that come in at 7 day apart. And then we look at the retention of their bile salts. And if you have 0 to 5% retention, then it's, the test is severely abnormal. The reason why I think it's really important is that actually you can see you can make a significant impact in some of the things after treatment. But the really interesting things about bile salt malabsorption is that the patients who have the severe bile salt malabsorption will have the biggest impact from treatment. And about 50% will respond to cholestyramine if they're taking properly, which is our first line of choice, although there's nationally a shortage of getting cholestyramine at the moment. I tend to prescribe Questron Light because it's just apparently a bit more palatable and slightly better tolerated, and titrate up from half a sachet a day up to 2 sachets a day. Some of them will need the full 4 sachets a day. The patients who don't respond to cholestyramine, vast majority will respond to cholesevelam. We build it up to 6 tablets a day, so it's 6 to 5 milligram tablet. You build up to 6 tablets a day of about 6 or 7 days. And there is a bit of data to suggest that you should be taking most of these tablets before they go to sleep because of the bile acid synthesis. And also they're difficult things to take because you have to avoid other medications from within 2 to 4 hours before and afterwards. So if you have lots of patients who are taking medications 3 times a day, it's a real pain to take these drugs. But if they work, patients have had, that you've completely changed their life, and then they just reduce the frequency. Microscopic colitis is something that we know we miss. It's been described really since the 1980s, and these entities where colon looks entirely macroscopically normal. So you do colonoscopy as entirely macroscopically normal, but when you take serial colonic biopsies, you have, as you can see, histology slides here. The top is collagenous colitis. I have a pointer. The bottom one is lymphocytic colitis. So you're having an increase in lymphocytes in lamina propria, which is a really important distinguishing. So you have to have increased lymphocyte in both conditions. But right at the top, you can see this collagen band in collagenous colitis. It's highlighted there with green. And we know that actually prevalence is somewhere between 50 and 200 per 100,000. It mainly occurs in women. About 60 to 70% of the cases occur in women. And mean age of presentation is at 60. But we know that up to a quarter of patients present under the age of 45. So it's still something to think about in younger population. It's associated with other autoimmune diseases and then drugs. So lansoprazole is the commonest cause of microscopic colitis. So in fact, actually, old school gastroenterologists still don't organize a colonoscopy, but they just stop lansoprazole and patients get better. Non-steroidals, but interesting, sertraline, which is an incredibly common drug that's associated with microscopic colitis. Colonoscopy is what we've always advised doing because you pick it up more in the right-sided biopsies than the left-side biopsies. But in fact, actually, it's only in the rectum that you don't tend to pick it up. So there are some places that say that if you do flexible sigmoidoscopy and you get up to splenic flexure, that's probably good enough. But actually, you're probably going to do colonoscopy to exclude organic pathology anyway. Now, what about this entity of malabsorption of carbohydrates? Lactase deficiency is the commonest one. We know that about 68% of the world population doesn't have lactase or develops lactase deficiency. You can develop it after acute gastroenteritis. It can be completely idiopathic. In Han Chinese, that goes up to about 100%, so they don't have any lactase. Again, what I say to patients is that adult humans are not meant to be milk consumers. So normally, pragmatically, instead of sending them for the test, I normally stop patients having milk, and it's usually pretty spectacular. They will their symptoms stop immediately. And bear in mind that even people who have severe lactase deficiency can still take up to 100 mils of milk. And the harder cheeses have significantly less lactose, so they can still have dairy to an extent. And then we have this entity of fermentable oligodimonosaccharides and polyols, FODMAP, which I'm sure you've heard about. And I often wish I'd written one of these books because then I wouldn't be here, but I'm in some nice Caribbean island having made my fortune in selling healthy gut. Because, of course, if you have no FODMAPs, you're completely well and you're really happy and your life is perfect. But there is some evidence, actually. I'm being pedantic. It works. It works in some patients, and I use it a lot. So that's a first caveat I would say. And what do we think happens to these patients? So some food groups, so some of those fermentable things, the fermentable is the key word here, is that these foods don't break down before they come into the colon. And when they come into the colon, they cause all sorts of problems. So they cause excessive secretion of water, so you get osmotic diarrhea. They come into colon and cause bacteria that normally live in your colon, fermented, so they produce hydrogen and methane. And then you get luminal distension, bloating, and abdominal cramps. And there's your typical patient who comes and says, I look like I'm 9 months pregnant, and I'm always really big, and I'm always really windy. There is really quite good data that if you reduce FODMAPs in some of these patient groups, their symptoms improve. Why they suddenly become intolerant to FODMAPs is not clear. So why is it suddenly that you go through your entire life and you're absolutely fine and able to tolerate everything, and then suddenly you can't have artificial sweeteners, is really far from clear. There is a bit of suggestion that, again, we come back to the gut microbiome. There's the gut microbiome modulating this, and whether there's a change in gut microbiome is not clear. I'm going to finish off with my least favorite diagnosis, and probably the one I see increasing number. I see increasing number of particularly young women who come to clinic and say, I've got SIBO, I'd like some rifaximin, please. So what is SIBO? SIBO is very trendy, and everyone's got SIBO. And as you can see, Amy Myers, MD, has made quite a lot of money out of SIBO and how to treat it, together with all various generalized antifungal treatments. Again, we know very little about it. When I was in medical school about a million years ago, now what it feels like, we thought that there were no bacteria in a small bowel, and the only bacteria that we ever found were in a colon. And then we, did a bit more work and had better equipment, and we think that in the small bowel, the concentration of bacteria is less than 10,000, so less than 10 to the 4 colony forming units, compared to the large bowel, which is in excess of 10 to the 10, 10 to the 12. What we now know, that there are certain conditions, and we've known this for a long time, haven't we, empirically, in the patients who've had particularly upper GI surgery, patients with systemic dysbiosis which alter the transit through the small bowel, get better after antibiotics if they have diarrhea, if they have bloating. And therefore, there's this presumption they've got small intestinal bacterial overgrowth. What we don't know is how to diagnose it. So we're not sure how to diagnose it. We think maybe if you call it more than 10 to the 6, maybe that gives you symptoms. But actually, when you look at elderly population with functional disorders, they've all got predominance and higher concentration of bacteria in their small bowel, and none of them have symptoms of SIBO. So one doesn't follow the other. There are obviously, when you have structural and transit problems, there are obviously, you can imagine intuitively why it would happen, because the thing just is moving quickly through the small bowel, and therefore some bacteria there perhaps overgrow. But are they actually related to your symptoms, and what do they cause? It's really not clear. I haven't put anything on diagnosis because it's so complicated. So the breath test, which is available in some parts of the country, is so poorly sensitive and specific because it relies on a standard oral cecal time. And of course, I don't know if any of you do capsules, you probably don't, but my colleagues who do lots of capsule endoscopy say you have no idea how the oral cecal time varies so much more than we ever used to think. So some people just have incredibly fast oral cecal time without any symptoms, and some people have incredibly slow. And the breath test relies entirely on the fact assuming the oral cecal time is 90 minutes, and that's just it, and nothing else. So the sensitivity of it is poor, specificity is poor. Jejunal aspirate are thought to be gold standard, marred by complications. Contamination, how do you actually get jejunal aspirate? And we now know that the stuff you get inside the lumen is not really the same stuff that you get on mucosa, i.e. the bacteria in the lumen of our gut is not the same as the bacteria that live on the lining, on the mucosa. What does it make? And my biggest thing about this is for some of these young patients without any risk factors, are you actually confining these patients to monthly antibiotics for the rest of their life to treat this? It just doesn't make sense. They're going to run in more risk than benefit. And so I tend to treat their visceral hypersensitivity in the first instance to try with a bit of amitriptyline, and they tend to get better. So really, just to conclude, I'm sorry, it's been not particularly evidence-based because it hasn't changed, but I suppose from a clinical perspective is make sure the patient actually does have a diarrhea, because they all mean different things, and they all think that whatever they have is diarrhea. and rule out medications, which are the biggest cause of loose stool. I think it helps when you divide it into what subtype it is, because I think it tends to guide investigations, although should all get really those routine blood tests and colonoscopy. And then after that, you may choose to refer them to your local friendly gastroenterologist. And we do sometimes consider factitious diarrhea, laxative abuse. So I suppose the initial investigations in your clinic are really to include neoplasia. That's what we're all worried about, missing about, and that's the diagnosis we all think. And I think it's very reasonable to do that first. And then either stick with them if you have an interest, or refer to someone else who's got a bit more interest. Thank you.
Thank you very much. Pretty comprehensive. I wonder if you've got some questions. You've covered an awful lot there, and a lot of it will be less than every day.
Oh, it was a really good presentation. Thank you. It was very helpful. This is something slightly off-piste, but I just want to ask, from the back of my memory a long time ago, there was a pediatric case for a child that needed a right hemicolectomy. And I still remember the pediatric gastroenterologist saying they need 4 weeks of antibiotics because something about the reflux of the bacteria into the small bowel, because they've lost their ileocecal valve. And I can't remember why at all for pediatrics. Is that anything?
Yeah, so that's interesting. So in fact, patients really cottoned onto this, and they say, I think I've got, even if they've not had hemicolectomy, they'll come in and say, I've got patent ileocecal valves, so some of my gut bacteria might be refluxing in my terminal ileum. Clearly, there are documented cases of colonic, and we know that concentration of bacteria changes as you go down from proximal small bowel down to the distal. And your ileum, the concentration of your bacteria is pretty much the same in your colon. So we wouldn't do that routinely. Pediatric gastroenterologists don't do it routinely anymore. But I think at the time, there was a bit of excitement along the time, probably when we were working out that there are some bacteria in the small bowel, and we disregard them all this time. And the problem with this is that they don't correlate with the symptoms. So I have a number of patients who have a positive breath test, and you give them antibiotic, and they have a negative breath test, but their symptoms are completely unchanged. So to me, it's a powerful thing, including lots of data about the patients we know have high small bowel bacterial growths, but they don't have any symptoms at all. It's really very complicated, but we don't do it routinely anymore.
Any other questions?
Hi. So in terms of post-cholecystectomy diarrhea, are there any factors that predict who's going to get it?
No.
No.
They're a bit like the patients who write up a quadrant pain who have a gallstone, and we don't know whether they need cholecystectomy, and you don't know whether they need cholecystectomy. And so what I say to them in clinic is, you've got to have your gallbladder out, because until you have it out, we're never going to know whether the gallstone is causing your pain. And about 50% of them come back to my clinic saying, I still got the same pain as before. And then I say, okay, we'll have a bit of amitriptyline this time, because it's not that. There are no predictors, unfortunately, about who's going to get it. But it's just something to bear, if they come in diarrhea and they've had cholecystectomy, it's worthwhile trying and thinking, well, it might be that.
Can I just ask about probiotics? Get patients coming into clinic who have read all this. Do you recommend them, or what do you feel about them?
I love probiotics. At least you give them something, and it doesn't cost the NHS because they have to buy it. So probiotics are really interesting. There is quite reasonable data in IBS, diarrhea-predominant IBS literature, about the probiotics decrease the symptoms of bloating and decrease diarrhea in certain patients. Simprove was one of the first ones that was tried. It's a liquid probiotic. It's incredibly expensive. I think something like £20 per bottle. And the company, Norgin's taken it over now, tried to sign them up for like a 3-month trial or something like that. 12-week, I think 12-week step to a healthy gut. It's a liquid. They say that it's much better because it's a liquid form, so the bacteria have never been freeze-dried. They have to take a little cup first thing in the morning. The evidence is there. Bear in mind that the placebo effect is about 40% in those trials, but actually they don't do them any harm. So actually I'm quite upfront with my patients. I say we don't really know if it is the bacteria, because of course there's all this data, do these bacteria actually reach colon alive? Do they actually, can they get through all the gastric juices? They quite clearly can, because otherwise none of us would ever get Salmonella or Shigella or any of the other gastrointestinal things if our gut was so sophisticated. But actually it doesn't matter. If it makes them feel better, it works for them. And I have some patients who do. So I normally say a month of each probiotic. Doesn't matter. I tend to use Biocolt, which they can buy, just is widely available in Boots. But any gut-friendly probiotic, a month, try a different one if it doesn't work. you know, some patients, I mean, I'd say probably in my practice about half will get some benefit from it.
Anyone else? I've got a question. We haven't got access to CCAT scans, and we seem to be taking huge numbers of biopsies, like huge numbers of biopsies for microscopic colitis. And you know, you have clinical suspicion that people might have bile salt malabsorption. It sounds like you can get it through your life at the drop of a hat from time to time anyway. What do you think about treating these patients empirically?
So that's always been the case, isn't it? Do you treat them empirically or not? The latest guidelines, the latest VHG guidelines actually come down quite so nice. If they haven't, they're about to proclaim on the use of CCAT. So there is quite a bit of data to show that if the patients have positive diagnosis, they're more likely to stick with treatment. Cholestyramine is a really quite unpalatable drug. And the problem I have if you tried it empirically is that if they've not taken, you don't know whether they've not responded or whether they don't have BAM and it's not worked. But you're absolutely right. I mean, CCAT, again, is not gold standard. So we've got some data from the Marsden, where I do 1 day a week, where we have, in our post-radiotherapy patients, where we have had 2 CCATs with vastly different values. Because actually, as you say, they really alter. And I think, you know, we don't have a gold standard test.
Generally speaking, we should allow the gastroenterologist to fulfill their duty in differential diagnosis.
Yeah, so that we have something to do. No, I would say we have a real problem in this trust in that you have to have a really good water effluent in order to be able to dump very much radioactive selenium. We don't have enough. So our nuclear radiologists here are really quite tight. And in fact, I spoke to him the other day saying we've got a limit to how many CCATs we can do. So in fact, actually, our finding here is that most of our CCATs, the requests are positive because we really try and filter the patients that we think are likely to have it positive.
Okay, so another question. So we'll definitely refer all the patients to you for these tests. Are there any specific symptoms that you think are really useful in directing you down to an irritable bowel syndrome diagnosis? For you, I know the criteria, but anything in your practice that makes you think, right, this really looks like an IBS case?
Yeah, so you know, it is much more common in women than in men. So if you've got a young woman in her 20s who's got really stressful life, or you know, has got young kids, 3 young kids running around, or particular stress, it's going to direct you more. In terms of symptomatology, we always used to say that absence of nocturnal symptoms completely means that it's much more likely to be functional. But I do have a number of IBS patients who wake up at 5 o'clock in the morning to go to the toilet. So even though that was very textbook of nocturnal symptoms, if they're fine overnight, then it's likely to be functional. It's not quite as clear cut as that. But as I say, by the time they come to you to secondary care, you're going to end up doing colonoscopy. I mean, I just don't think there's much role for not doing something, because I know that GPs have had a long time trying things in the community for these patients, which hasn't worked.
And do you take biopsies for microscopic colitis routinely at your colonoscopies for patients presenting with diarrhea?
I do.
Yeah.
Yeah. So they all get biopsies. So interestingly, if I'm assessing colon for UC, I wouldn't take biopsies. I'm very against taking too many biopsies. I don't think you need them. So if you're assessing UC, you don't need biopsies. You can easily describe what you're seeing. But actually, if you've got completely normal colon and you think it's microscopic colitis, then I definitely do. I don't need to take them from the rectum. We know the rectum doesn't have any yield, so I just take a few proximal biopsies, usually ascending colon transverse.
Just 2 or 3?
Yeah.
Fine. And more sensitivity on the right side of making the diagnosis.
Much more sensitivity on the right side. Rectum is just not good enough, but probably dated if you go more proximally in sigmoid, you'll get a positive result as well.
Right. Well, Dr. Wilson's also an expert endoscopist. So if anyone's got any burning endoscopy questions, I don't think we're going to run the little group discussion before lunch because we've already overrun. So if there's any other questions for her, that would be excellent. But if not, we'll have another. Oh, excellent. One more.
It's more on. I was just thinking about it. In terms of Crohn's and ulcerative colitis, do we know, this might show up a massive hole in my knowledge, but do we know why UC stops at the ICV? Is it because of the bacteria? I mean, is there a...
Yeah, no, that's a really good question, and we don't know. So the traditional description of UC, the way that we will learn it in the textbook, is that it starts in a rectum and spreads proximally. But we've certainly had, you know, bear in mind that we now do things a lot differently than we did when some of those things were described, textbook definitions. So there's a real interest. There are 2 cohorts of interest, which are the patients that we colonoscope for other reasons. So for example, patients with serrated polyps who are young patients come for frequent colonoscopy. And we've had at least 2 or 3 that we've picked up inflammation, which has started on the right side. So they had inflammation on the right side before developing rectal inflammation, which is something that turned out to be UC, and they had no symptoms, so it's pre-symptomatic. And the same with bowel cancer screening program. So patients come in FOBT, completely asymptomatic, and we end up picking inflammation sort of in descending transverse. Why UC stops at ileocecal valve is not clear. I suspect in not too long future, we won't be talking about Crohn's and UC. We'll be talking about very different tests. And if you've listened, I mean, I don't think Elsa went into detail, but there's some really exciting work on genomics and personalization of medicine, which is being driven about that there are certain genes that are associated with certain distribution of disease. So I suspect very soon we will be talking about, you know, Crohn's colitis and UC colitis might actually be merged in a sort of group. They'll be more site-specific and behavior-specific rather than the arbitrary definitions which we have at the moment. So,
Thank
because
you
of
so
course,
much.
sorry to interrupt you,
carry
because of
on.
course, you know, the interesting thing is pouchitis. So patients have pouches, and then they get pre-pouch ileitis. What is that? Why have they got pre-pouch ileitis? Is that UC? No, we don't call it UC, do we? We call it pre-pouch ileitis. But it can be kind of extensive. I mean, we've given anti-TNF for patients who've had pre-pouch ileitis for about 30 centimeters. Yeah, backwash ileitis in a normal or in a pouch. We sort of call it pre-pouch, but backwash ileitis in a pre-colectomy colon. But no, we have a post-pouch in a sort of massive segment of pre-pouch ileitis, and it's, you know, is that UC? Or is that you're going to call it Crohn's now because it affects the small bowel? It's sort of, it doesn't fit in neatly into the categories. I think we're sort of, I think the distinction with Crohn's and UC is really quite crude at the moment. I think it's we're going to have a lot more separate entities seen of this inflammatory disease.
Excellent. Last chance. Hey.
Sorry, that's all right.
Any thoughts about taking out the appendix to when the patient's got cold colitis to try and prevent further flares of ulcerative colitis? There's some vague mutterings about the
there is, and it was always the appendicectomy was protective, wasn't it? No, is the answer. We haven't moved any further, but it does make you think, and you know, often it makes us think. So the patients have proctitis only, and it comes back to the whole bacteria thing. The patients have proctitis only, and will have a cecal patch and periappendiceal inflammation. Is it there because bacteria? So one of the theories is that the bacteria in the appendix are more static and in higher concentrations because there isn't a flow through and therefore allows it to build up. So is it related to bugs? Maybe, but no, not in terms of clinical practice really.
This is related to appendix. Can you use
That's very surgical.
Can you use appendix as in the right iliac fossa pain as a biopsy for IBD or Crohn's disease?
Can you
use it as a biopsy? So if you go for right iliac fossa pain,
yeah,
you put a scope in, you don't find a cause. Take the appendix out, send it for biopsy, and see if there's any Crohn's in it.
Well, it will be looked at. So it's not something I've ever come across, I have to say.
No, I'm not about it. I mean, as you know, we stay from the appendix at endoscopy. We're very scared of the appendix. We, you know, when we see it, we sort of stay further away, and we go edge to the, you know, to the lip of the opening, and then stay far away. In fear of having to call one of you guys, please.
It's tiger country.
It's ruined my figures for the year.
What I'm trying to say is instead of, you know, doing another investigation later on with a colonoscopy, take biopsies from inside if you don't find, if the right iliac fossa pain persists. Can you use the appendix reliably as saying?
No, I think the answer is no.
I
Yeah,
think
no.
that probably is not.
Yeah. Okay. Excellent. Any more? Lunchtime. We'll meet at 1 o'clock for our next lecture.